So segmentectomy for ground glass dominant lung cancer with a tumor diameter of 3 cm or less, including GGOs, pure GGOs. And this is a very interesting way of conducting surgical trials now, because it's getting more and more difficult to randomize patients in early lung cancer. So I'll just give you a brief background. So at this, when this study was being conducted, they already had a trial ongoing in Japan. This was done between 2010 to 2020. Over the 10 years, Japan conducted 3 seminal studies on very early lung cancer from the screening patients that they were receiving after the screening trials were ongoing in Japan. So this is a study where they were studying the effect of peripheral GGOs, and when they mean peripheral GGOs, they mean a consolidation to tumor ratio of less than 0.25. That is, less than 1/4 of the tumor had a solid component. And in these patients, because they couldn't randomize because many of these patients were surgically treated, and in Japan, they diagnose patients by radiology rather than by histology. So they don't go behind and prove that the patient is malignant before taking up for surgery. So these patients had either a wide wedge or a segmentectomy, and they found that in these particular patients, if they had cancer, the 5-year relapse-free survival rate was more than 99.7%. So, and none of these, in this study they had 314 patients totally, with a morbidity of 5.4%, no deaths and no recurrence over a 5-year period. Absolutely stunning results. So this is for GGOs with a very low solid component, where they could not do a lobectomy because it would be unethical to do a lobectomy in these patients when you don't have a diagnosis. And in these patients, the results were so good. And the next study, which was conducted almost in a similar time period, was the JCOG 0802 study, and I think there's a speaker who's going to speak about it. Here they found that segmentectomy was non-inferior to lobectomy for very early stage lung cancers less than 2 cm in size. And there the CTR ratio was more than 0.5. So in this particular study, so we had 3 studies. So the 2 that I mentioned, one for pure GGO, other for established cancer, and this third one was for something in between. Again, I have this group of patients which are stage 1, again less than 3 cm in size, but they termed this thing called dominant GGO. So dominant GGO they meant was less than 0.5 CTR. So and it was a single arm. Similarly, they could not do a lobectomy for randomization in this group, so it was a single arm, non-randomized confirmatory study, because they had already confirmed from previous studies the segmentectomy or wide wedge was good enough for GGOs. The intervention was segmentectomy and was done across 42 institutions in Japan, and the outcomes were similar: 5-year relapse-free survival as primary outcome. Secondary outcomes were OS, DFS, percentage FEV1 change, successfulness of a segmentectomy, R0 section, and adverse events. So this is how they selected cases. Because already 3 studies were ongoing, they selected these particular patients. Anyone with a CTR ratio, consolidation to tumor ratio of 0.5 or less with 2 to 3 centimeters in size. Remember that JCOG study 0802 limited the size criteria of the lesion to 2 centimeters. Here they included up to 3. And then there was a certain group of patients who were left out from the previous pure GGO study. This group of patients where the tumor size was less than 2, but the CTR was between 0.25 to 0.5. And again, tumor size less than 2 with a central location tumor. So these special situations were allowed. So across these 3 studies that they did in Japan, they include the entire gamut of early lung cancer patients. So this is a busy slide, but they started off with 396 patients, and the final analysis down below is for 346 patients. 19 patients underwent a lobectomy in this group. Around 1 patient had a residual tumor was an R1 dissection, so they excluded them from the analysis. And they had a lot of non-invasive lesions also, benign lesions, and so they excluded them for the final analysis. So very impressive surgical results. You can see down below there that almost 95% of the patients underwent minimal access resection. Almost 100 for all the patients who they tried getting a segmentectomy done, 95% of them landed up having a segmentectomy done. only 5% of the patients had a lobectomy done. And when you analyze them, particularly you can see they have very impressive surgical results with blood loss of being very minimal and a good surgical time also. You can see between the two red bars are actually a high volume of these patients were atypical adenomatous hypoplasia, adenocarcinoma in situ, minimally invasive adenocarcinoma. In my career of 10 years of thoracic oncology, I have operated only 3 patients with these 3 diagnoses. So almost 90% of the patients belong to this group, and then a few other patients belong to the invasive adenocarcinoma group. These are the surgical outcomes. For those who they attempted a segmentectomy, around 92% of the time, 92.5% of the time, they were able to succeed. 95% was the segmentectomy rate, but then a few of them they converted them to a lobectomy because of inadequate expansion of the residual lung. So you had an increase of 3.5% for that. Median tumor size in this group was around 15 millimeters. Of that, the median invasive component of the tumor was 3.8 millimeters. The N1 says only one patient of the 356 had an N1 node itself. No N2 node was seen in this group. 99% of the patients had a R0 resection rate, and the medial surgical margin was around 25 millimeters. And these are the outcomes of 357 patients. 98% 5-year relapse-free survival and overall survival. Confidence intervals are so narrow, that I don't see any other country even achieving this kind of result. Like I said, only one patient in the segmentectomy analysis group had a N2 lymph node. Most of the patients were 1A1, only one R1 resection, only one local regional recurrence, and distant recurrence only one when you include the entire group. Total number of deaths, there were no mortality in the surgical arm, and yeah, one more slide. One more slide. Yeah, this is an important thing that we need to see, that the randomized trial which they showed, segmentectomy versus lobectomy, this is their results comparing their own 2 studies. The randomized trial of segmentectomy is the one that is shown in blue. That study had a more detriment in pulmonary function test compared to this study. They don't know the reasons why. So they concluded that segmentectomy is now the standard of care for GGOs or predominant 2 to 3 centimeter GGOs if adequate surgical margins can be secured. And they also say that future studies, because the surgical results are so good, we should try and consider non-surgical approaches. And thank God they didn't involve some drug in this. They didn't involve some drug in this. So this can be done only in Japan, and the reproducibility of segmentectomy among institutions is difficult to. No radiology, because most of these were diagnosed by radiology. I think we are almost 15 years behind in this aspect. Thank you so much.